She had been to the optometrist 3 times in 4 years. Each time she left with a stronger prescription. The reading glasses she bought after each visit helped for a few months. Then the difficulty returned. She had assumed her eyes were simply getting worse in the way that eyes do. Her optometrist had mentioned her mild cataracts. There, but small, not significant enough to explain her vision complaints. She was told the cataracts would eventually need surgery when they matured. In the meantime, keep updating the prescription. What nobody had done in 3 visits over 4 years was ask her to describe exactly what the difficulty was, not whether things looked blurry, but how they looked blurry. Because if anyone had asked, she would have described something that is not cataracts, has never been cataracts, and that no prescription lens can address. She could not tell a cup from a plate when both were on the table unless she looked directly at them. She had started bumping into furniture on her left side. She had trouble recognizing faces she knew well when they entered a room from an angle. She could read a word if she stared at it, but lost the surrounding text. When her neurologist finally ordered an MRI after she failed a cognitive screen at a routine physical, the scan showed posterior cortical atrophy, a specific pattern of neurodegeneration beginning in the visual processing areas of the brain that is, in many cases, the earliest visible expression of Alzheimer's disease. She had been managing it with reading glasses for 4 years. Blurry vision after 60 is reflexively attributed to cataracts. Cataracts are common, affecting approximately 70% of adults over 75, and they are a genuine cause of genuine vision impairment, and I am not going to minimize their significance. But cataracts have a specific pattern, a specific quality of visual impairment, and a specific relationship to lighting conditions that distinguishes them from several other causes of visual disturbance in older adults. Causes that are not in the lens of the eye, but in the blood vessels feeding the eye, in the nerve fibers connecting the eye to the brain, and in the visual processing areas of the brain itself. Some of those other causes are neurological warnings, some are cardiovascular emergencies, and one specific pattern, the one I just described in the woman who could not distinguish her cup from her plate, is one of the earliest and most consistently missed presentations of neurodegenerative disease that the entire field of geriatric medicine encounters. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. Visual symptoms in older adults require professional evaluation, and some of the presentations I am going to describe, particularly the sudden onset ones, require same-day emergency evaluation. I am giving you the clinical framework to understand the difference between the visual change that can wait for a next available optometry appointment and the visual change that requires an emergency room today. That distinction may save a life. Subscribe to this channel right now before we go further. The visual warning signs I am about to describe are among the most consistently missed clinical findings in senior health, and the neurological and vascular conditions behind them are among the most time-sensitive. Subscribe now, it is free, and stay with me for the complete framework. Let me start by describing what cataracts actually look like so you can compare every other visual symptom I describe against this baseline, because most people with cataracts do not know what the specific cataract visual signature is, and that knowledge is the foundation of recognizing when what you are experiencing is not cataracts. Cataracts form when the crystalline proteins of the eye's lens accumulate oxidative and glycation damage over decades and progressively lose their transparency. The lens becomes progressively more opaque, scattering and absorbing incoming light before it can be focused on the retina. The visual consequence is specific. Objects appear hazy, dim, or less contrasty, particularly in conditions where bright light is involved. Glare from headlights at night is typically the earliest complaint, followed by difficulty in very bright outdoor light. Colors appear washed out or yellowed. Vision deteriorates roughly symmetrically in both eyes over months to years. The Snellen eye chart, the letter chart used to measure visual acuity, shows reduced performance, but the reduced performance is consistent and proportional to how bad the person feels their vision is. The key characteristic of cataract visual loss is that it is optical. The image reaching the retina is blurry because the lens is not transmitting it clearly, and the blurriness is roughly uniform across the visual field. Everything looks slightly fogged, every detail is slightly reduced, and the vision, while worse than it was, is still recognizably a version of normal vision. These are the hallmarks of cataract: gradual bilateral symmetric onset, glare sensitivity, reduced contrast and color, consistent with measured acuity reduction, and a visual experience that is uniformly dimmed rather than selectively disrupted. What I am going to describe now are the visual changes that do not match this pattern, the ones with sudden onset, the ones affecting only one eye, the ones involving loss of part of the visual field rather than uniform dimming, the ones where the measured acuity on the chart is acceptable but the person cannot function visually in daily life, the ones where other symptoms accompany the vision change: headache, jaw pain, jaw fatigue with chewing, scalp tenderness over the temple, speech difficulty, limb weakness, or a feeling that a curtain is descending over one eye. Each of these patterns points away from cataracts and toward a specific alternative diagnosis, and each of those diagnoses has its own urgency and its own intervention pathway. The first and most urgently important non-cataract visual pattern is sudden transient monocular visual loss, vision loss in one eye that lasts seconds to minutes and then resolves completely. This presentation is called amaurosis fugax, Latin for fleeting blindness, and it is a medical emergency that is frequently dismissed as an ocular migraine, a pressure on the eye, or a momentary circulation issue that resolved on its own and therefore need not be investigated. Amaurosis fugax is the visual presentation of a transient ischemic attack, a TIA, in the territory of the ophthalmic artery, the first branch of the internal carotid artery supplying the ipsilateral eye, when a small embolus, a fragment of atherosclerotic plaque, a platelet aggregate, or a cardiac thrombus, temporarily occludes the central retinal artery or one of its branches. The retina loses its blood supply for the duration of the occlusion. When the embolus moves on and blood flow is restored, vision returns. The person experiences a dramatic loss of vision in one eye, often described as a gray shade or curtain descending from above or from one side, lasting anywhere from seconds to 15 minutes, followed by complete or near-complete restoration of normal vision. Because the vision returns, most people do not seek emergency evaluation. They tell their optometrist about it at their next routine appointment, or they mention it to their primary care physician weeks later. This is precisely the wrong response. Research published in The Lancet established that the 90-day stroke risk following a TIA, including TIAs presenting as amaurosis fugax, is approximately 10 to 15% without treatment, and as high as 25% in the highest risk subgroups. The ABCD2 score, which predicts short-term stroke risk after TIA, has been validated across multiple large cohort studies and consistently shows that the 2-day stroke risk after high-risk TIA features can reach 8% or more. This means that a senior who experiences sudden transient vision loss in one eye waits 2 weeks to mention it at a routine appointment, and is reassured that it was probably nothing, has navigated a period of substantially elevated stroke risk without the antiplatelet therapy, statin optimization, blood pressure management, and carotid imaging that the TIA guidelines indicate should begin within 24 hours of the event. The specific characteristics that distinguish amaurosis fugax from benign visual symptoms: sudden onset rather than gradual, lasting seconds to minutes rather than hours to days, or being chronic, affecting one eye rather than both, resolved completely rather than leaving a persistent deficit, and most importantly, no associated eye pain, no floaters, and no other symptoms of retinal detachment. If you or someone you know experiences sudden vision loss in one eye that resolves spontaneously, the correct response is not to wait and see if it happens again. The correct response is same-day emergency evaluation because the investigation required carotid ultrasound, cardiac evaluation for atrial fibrillation and valvular sources of embolus, brain MRI with DWI sequences to detect silent infarction. Needs to begin within hours, not days. Subscribe to this channel right now because I have 3 more visual warning patterns to describe, and the second one is the one that is most commonly confused with cataracts and most consistently delays a diagnosis that changes the entire management of a neurodegenerative condition. Subscribe. It is free, and let us continue. The second non-cataract visual pattern is the one I described in the opening story: progressive difficulty with visual tasks that cannot be explained by optical measurements. The acuity on the Snellen chart is adequate. The person can read the letters when they stare directly at them. The prescription is up to date. The cataracts, if present, are mild. But the person cannot function visually in ways that their measured acuity would predict. They lose items in plain sight. They misjudge distances, reaching past objects they are trying to grasp. They have difficulty reading despite adequate acuity for individual letters because they lose their place in the line or cannot process the spatial layout of the page. They may have difficulty recognizing familiar faces when seen from an unfamiliar angle. They bump into objects on one side. They have increasing trouble with tasks requiring spatial judgment, pouring liquid without spilling, driving in traffic, navigating familiar environments. This constellation of symptoms is called posterior cortical atrophy, PCA, and it represents the clinical presentation of neurodegeneration beginning in the visual processing areas of the brain, the primary visual cortex in the occipital lobe, the dorsal visual stream running through the parietal lobe that processes spatial location and object-directed action, and the ventral visual stream running through the temporal lobe that processes object identity and face recognition. When these areas begin to accumulate the same amyloid plaques and tau tangles that define Alzheimer's disease in other brain regions, the result is not memory loss, at least not initially. The result is a progressive erosion of visual processing capacity that the person experiences as a visual problem and that their physicians, reflexively attributing visual symptoms in older adults to optical causes, investigate with lens prescriptions and cataract evaluations while the neurological window for early intervention closes. Research published in JAMA Neurology examining the diagnostic timeline of PCA patients found that the average time from first symptom presentation to correct neurological diagnosis was 3.8 years. During that period, the majority of patients had received at least 2 new eyeglass prescriptions. A significant proportion had cataract surgery that did not improve their functional vision, and virtually all had been reassured multiple times that their optical findings explained their symptoms. The neurological diagnosis, when it finally arrived, was almost invariably made by a neurologist rather than the ophthalmological or optometric practitioners the patient had been seeing repeatedly. The critical clinical test that distinguishes PCA from optical causes of visual impairment is not a visual acuity test, but a visual perception test. Specifically, tests of simultanagnosia, optic ataxia, and oculomotor apraxia, which together constitute the Balint syndrome triad of PCA. A simple bedside test: show the person a complex visual scene, a detailed picture with many objects, and ask them to describe what they see. A person with PCA can often identify individual objects they focus on, but cannot perceive the spatial relationships between objects or construct a coherent narrative of the whole scene. A person with cataracts can perceive the whole scene. It simply appears dimmer or hazier than it should. I want to spend more time on the PCA diagnostic gap because it represents one of the most preventable delays in Alzheimer's diagnosis in the current medical system, and because understanding the specific visual tasks that are impaired changes how family members and caregivers interpret what they are observing. Posterior cortical atrophy does not affect memory in the early stages. The person can tell you exactly what happened yesterday, where they put their keys, and the names of everyone they know. What they cannot do is read comfortably, despite a current prescription. They cannot pour liquid accurately. They cannot judge whether there is enough space to park a car. They misidentify objects in their peripheral vision as things they are not. They may have difficulty dressing, not because they have forgotten what clothing is, but because the spatial relationship of garment to body and the orientation of the garment have become difficult to process. They may have difficulty recognizing emotion in faces. They frequently develop alexia, difficulty reading, because the spatial processing required to track left to right across a line of text and to group individual letters into words is a function of the posterior parietal cortex, not the eye itself. These symptoms are not explained by cataracts. They are not explained by dry eyes. They are not explained by glaucoma. They are explained by neurodegeneration in the visual association areas of the brain, and identifying them early, before the temporal, frontal, and memory networks are significantly involved, is when the emerging disease-modifying therapies for Alzheimer's have the greatest potential benefit. The person who gets the right diagnosis at year 1 rather than year 4 after symptom onset has more options than the person whose optometrist kept updating their prescription. The third non-cataract visual pattern is the most time-critical of all, and I want to be very specific about the symptoms because the window for preventing permanent blindness from this condition is measured in hours. Giant cell arteritis, also called temporal arteritis, is an inflammatory vasculitis of medium and large arteries that affects almost exclusively adults over 50, with peak incidence in the 70s. It causes inflammation and granuloma formation in the arterial wall of the temporal artery, the ophthalmic artery, and the posterior ciliary arteries that supply the optic nerve. When the posterior ciliary arteries become inflamed and occluded, the optic nerve loses its blood supply and undergoes ischemic optic neuropathy, a sudden, painless, but catastrophic and largely irreversible loss of vision that typically begins in one eye and progresses to the other within days to weeks if untreated. The visual presentation of giant cell arteritis may be preceded or accompanied by specific systemic symptoms that are pathognomonic, so characteristic of this condition that their presence should trigger immediate investigation. Jaw claudication, the development of aching jaw pain or jaw fatigue during chewing, particularly with tougher foods, that resolves with rest, is the most diagnostically specific symptom, present in approximately 40 to 60% of cases. Scalp tenderness, particularly over the temporal region, is another specific finding. Many patients describe pain when combing their hair or resting their head on a pillow on the affected side. New onset headache in an older adult, particularly a temporal or occipital headache that is different in character from any previous headache pattern, is a cardinal symptom. Polymyalgia rheumatica, profound morning stiffness and aching in the shoulder girdle and hip girdle muscles, is present in approximately 40 to 50% of GCA cases and may precede the vascular symptoms by weeks or months. The laboratory finding is a markedly elevated erythrocyte sedimentation rate, ESR, typically above 50 millimeters per hour and often above 100. C-reactive protein is also elevated. These tests can be ordered in an urgent care or emergency department setting in the same visit during which the clinical history raises the concern. The treatment is high-dose oral corticosteroids, prednisone at 40 to 60 milligrams per day, initiated immediately before the temporal artery biopsy that confirms the diagnosis, because waiting for the biopsy to start steroids risks irreversible vision loss in the contralateral eye if treatment is delayed. Steroids do not make the biopsy negative if started within days of the first dose. A senior with new temporal headache, jaw claudication, and any visual disturbance requires a same-day emergency department visit, an ESR and CRP result that afternoon, and a discussion with the treating physician about whether empiric steroid therapy should begin before the biopsy appointment. There is also a specific pattern of visual disturbance associated with migraine in seniors that deserves mention because it is both common and frequently alarming when it occurs for the first time in an older adult without a prior migraine history. Migraine-related visual aura, the classic fortification spectrum of zigzag lights, shimmering arcs, or expanding blind spots that travels across the visual field over 20 to 30 minutes, can present for the first time after 60 in a condition called late-onset migraine aura, or migraine aura without headache, sometimes called ocular migraine. Unlike the visual disturbances I described associated with TIA, migraine aura typically develops gradually over several minutes. It does not begin instantaneously, and it affects the visual field rather than one eye. It looks like a television screen with static spreading across it, or like looking through broken glass, and it expands and migrates across the visual field over 20 to 30 minutes before resolving completely. It may or may not be accompanied by headache. The critical distinction from TIA and stroke-related visual disturbance is the gradual onset, bilateral field involvement, and the characteristic moving or expanding pattern. TIA visual loss tends to be sudden, monocular, and curtain-like rather than expanding. However, late-onset migraine aura is a diagnosis of exclusion in older adults, made only after cerebrovascular causes have been ruled out, because the symptoms can overlap and the stakes of missing a TIA are severe. A first episode of migraine-like visual aura in an adult over 60 with no previous migraine history warrants medical evaluation, not immediate emergency evaluation in most cases, but a prompt physician visit with a description of the symptom, its onset pattern, and its duration so that the appropriate investigation can be ordered. The fourth visual warning pattern is more common and less dramatic than the previous ones, but is among the most clinically significant as a window into systemic vascular health. The visual disturbances associated with blood pressure dysregulation in older adults. Hypertensive retinopathy, the retinal vascular changes that accompany chronic hypertension, produces its own visual signature that differs from cataracts. But more acutely, the blood pressure swings that are common in seniors, both hypertensive surges and the orthostatic hypotension that drops blood pressure upon standing, can produce transient blurring, dimming, or graying of vision that the person attributes to their eyes when the actual cause is inadequate or excessive cerebral and retinal perfusion pressure. The most clinically urgent blood pressure-related visual symptom is the blurring or loss of vision associated with malignant hypertension, a blood pressure surge severe enough to produce cerebral and retinal edema. In seniors with previously uncontrolled or suddenly escalating hypertension, a blood pressure above 180/120 can produce papilledema, swelling of the optic disc from elevated intracranial pressure, that presents as blurring, visual field deficits, or sudden severe headache with visual disturbance. This is a hypertensive emergency. Research from the American Heart Association estimates that neurological complications, including visual symptoms, are present in approximately 50% of hypertensive emergencies. A senior who presents with blurring vision and a blood pressure above 180/120 at a home cuff or clinic measurement requires emergency evaluation, not an optometry appointment. Orthostatic hypotension produces a different pattern, brief graying or tunnel narrowing of vision, occurring specifically upon rising from sitting or lying position, lasting seconds to a minute, and resolving with remaining upright. This presentation is the visual manifestation of cerebral hypoperfusion from inadequate blood pressure autoregulation on positional change, and it warrants an orthostatic blood pressure measurement and a medication review for drugs contributing to the hypotension, particularly alpha blockers, diuretics, and antihypertensives, rather than an ophthalmology referral. Before I describe the complete clinical action framework, I want to make sure you have heard the most important thing in this video, the pattern that connects all four of the visual warning signs I described. None of them look like cataracts, none of them are explained by a lens prescription, and none of them are being caught by the reflex that sends seniors with visual complaints to the optometrist rather than to the physician or neurologist who can connect the visual symptom to the systemic process causing it. Share this video right now, before the summary, with the senior in your life who has been told their vision complaints are cataracts, who has updated their prescription repeatedly without satisfactory results, who has experienced a transient visual episode they dismissed as nothing, or who has new headaches alongside any visual change. The visual symptom is the message. The brain is the sender. Share this now. Then come back for the action framework. Here is what to do in the next 48 hours based on everything you just learned. If you have experienced sudden transient vision loss in one eye lasting seconds to minutes that resolved spontaneously, this is amaurosis fugax until proven otherwise. Do not wait for a scheduled appointment. Call your physician today and use the words transient monocular vision loss. If you cannot reach a physician same day, go to the emergency department. The 90-day stroke risk window is open, and the investigation needs to begin within hours. If you have new temporal headache, jaw aching, or fatigue with chewing, scalp tenderness, or shoulder and hip morning stiffness alongside any visual disturbance, this is giant cell arteritis until proven otherwise. Go to the emergency department today. Ask for an ESR and CRP on arrival. Do not wait for a scheduled appointment. Do not wait for the headache to return. The window for preventing bilateral vision loss with corticosteroids is measured in days. If your vision complaints are progressive and do not match the cataract pattern, If you can read individual letters on the chart but cannot navigate visual scenes, lose objects in plain sight, bump into things on one side, or have difficulty with spatial tasks, request a neurological evaluation specifically for visual processing rather than another optometric prescription. Use the phrase progressive visual processing difficulty and ask your physician whether a referral to a neurologist specializing in cognitive visual disorders is appropriate. Ask specifically whether posterior cortical atrophy has been considered. If your visual disturbances are positional, occurring on rising from seated or lying position, and resolving quickly, ask your physician for orthostatic blood pressure measurements and a medication review. If your visual disturbances accompany headache or any blood pressure reading above 180 systolic, seek emergency evaluation the same day. At your next general eye appointment, ask your ophthalmologist to document not just your visual acuity on the Snellen chart, but your visual field by confrontation testing, your color vision, your contrast sensitivity, and whether your visual complaints are fully explained by the optical findings. If there is a discrepancy between how impaired you feel your vision is and what the optical measurements explain, that discrepancy is the clinical finding. Report it. Insist it be addressed. You now know that the eye is transparent in more ways than one. It is transparent to light, and it is a transparent window into the blood vessels, the inflammatory processes, and the neural networks that are running or failing to run behind it. Cataracts are common, but cataracts do not present suddenly. Cataracts do not present in one eye. Cataracts do not present with jaw pain. Cataracts do not prevent you from finding your cup on the table when it is sitting directly in front of you. The visual symptom your optometrist attributed to your lens may be coming from somewhere your optometrist cannot see. Subscribe to this channel if you have not already. My next video covers the 5 cardiovascular conditions that present with visual symptoms in seniors before any other warning sign appears, including one that produces a specific color vision change that precedes symptoms on a standard blood pressure cuff by years. Subscribe so it comes directly to you. I am Dr. Edward. Your eyes are not just eyes. They are the most visible part of your nervous system. Now you know how to read what they are telling you. I will see you in the next one.